All right, so as I mentioned this morning, we had all of our participants, and thank you for this, complete their content validation exercise, at least their assessment this year. And they have until April of 2021 to address all of their remediation issues. So I'd like to introduce Didi Davis, and she's going to enlighten us more about content validation and the importance of content quality. So thank you.
Well, thanks everyone. I promised to keep you awake this afternoon. So I had been asked by Jay to really give you some pointers, some tips as you're working with your customers, or if you're vendors, working with your customers. So participants, vendors, this is kind of a here's some tips and tricks from Didi. There have been a lot of folks that I've been working with literally for the past year and a half on this whole content testing piece. And really what we're doing is we're trying to do baby steps, one at a time to get this. This is a big problem. Content, the data quality does need improvement. And I'm very happy to say that the eHealth Exchange was one of the pioneers in trying to address this. So I'm going to be talking to you about several things. It's kind of a laundry list, so I've tried to give you an agenda here on the first slide to kind of cover overall the major topics that we're going to be addressing. These slides will be available, and I wanted to let you guys know that I've been brainstorming with some of the marketing staff and with Jay. I'm going to also take and do repeats of pieces of this using a subset of the slides, and maybe do some YouTube videos. Because I'm finding that nobody likes to read documentation. And nothing bad, I don't either, so I'm not trying to put you guys under the bus. But people are more willing to listen to YouTube videos and things, so we're going to try to do some other things to be innovative about how we push data out to you of how can you leverage the tools to really help remediate issues. I know some of you feel like your hands are tied, so also giving you some feedback on what we're doing to help you and assist you and support you there. So again, there's a mismatch. I'm not going to read all this agenda here, but this is something you can go back and kind of focus on, because I'm going to address each of these points one by one with the slides here. There's not that many slides. I'm probably going to take about 30 minutes to present, and hopefully that'll leave at least a good 10 minutes or more for question and answer. So that's kind of the process that we're going to follow here. So just for those who may be a little bit new to what we mean by content testing, I did want to include one summary fast forward slide of how did we get to where we are today and what we're doing today. So trying to make sure that everyone understands not only the history, but that this is something that the coordinating committee and the governance has really tried to push for quite a bit of time. So historically, this is something that the coordinating committee asked me through support to really look at how can we improve the data quality. Previously, we were using kind of like a wave of a hand. If we could find your system that you were leveraging actually in the chapel, or what's called the Certified Product Healthcare Listing, we would actually say no content testing required. So that's what we started off with. So we tried to keep the bar very low. Well, we found that that wasn't good enough, so we needed to improve it. So the coordinating committee empowered me to convene a work group for testing around clinical content. We had 2 co-chairs. We actually convened that work group in June of 2016. And it took us the 6 months to come up with, okay, what are we going to do to actually attack this problem? So we put together kind of a summary of, okay, we're just going to point straight to meaningful use, and we're going to pilot several different tools. I found 4 tools at that time in the industry, and we were going to pilot all 4 of them to see how they performed and how they could actually help us through this whole data quality improvement cycle that we need to go through. We wanted to have a tool that actually, if you look at the this graphic, and I can't point to that screen as well, but the graphic on the far right here, we wanted to make sure to interrogate the documents for not only the US realm header, which was part of meaningful use requirements, but all sections and all entries that are part of the body of the document. And I don't know if you guys know, but for instance, the CDA document, the C-CDA, the Continuity of Care document, is what most folks are using, but there's actually 14 different document types that folks can use. Everybody's trying to make a one-size-fits-all, make everything go into one document. But there's 70 different sections that you could use in documents, and all of these documents are open templates. So trying to figure out how to use the right document for the right purpose. So what we did was we took, did the pilot, got feedback, and we determined based on the pilot that we definitely needed to do testing. We proved that point. We had 20 organizations submit about 45 samples, and every one of them failed. So we said, yep, we've got to fix this problem. So it took us a while to get tooling completely up to the robustness it needed to be to do the testing the way we wanted to have some support for you guys. So we didn't launch the testing program until February 2018, but we set expectations of what was going to be tested in January of 2017. So we gave everybody a year notice. And then we started the testing, and we gave everybody originally a year to do the testing. And that didn't quite pan out. We had to do an extension, so we extended it to May, and not everybody was in yet, so we did the final extension to October 1. So basically what it boils down to now is, as of October 1, everyone has completed testing that were prior participants, and we're herding all the cats as they're coming in the door. So everyone, before they get onboarded, actually has to test content. So that's how we're doing kind of at least some support to let everyone know what they don't know. And that's the key, is making sure that they really know what they don't know. So that's what we started doing, and that's kind of the history of where we were and how we've gotten to where we are today. One thing to point out, and a lot of people ask these questions all the time, where do I know to get the value sets? What are the value sets? Especially those who are doing their own configurations of systems and so forth. All the value sets that we test against are all listed in the Value Set Authority Center called VSAC. It's hosted by the National Library of Medicine, and I've been working with HL7 for the past 3 years to make sure it's got all the value sets in it. When I first started this 3 years ago, it did not have, there was no source of truth for everybody to go to even find where the value sets were. So this is one place now. It took us 3 years to get this out there, but we do have all of it out there, and these can be downloaded. Now, for full disclosure, you have to have what's called a UMLS license. It's free, but you've got to designate somebody in your organization that's tied to an email that says, I am abiding by the rules and regulations. You agree to that. And so you need to make sure you have that. But basically, once you have the UMLS license, you can access all the value sets for not only CDA documents, but quality measures and everything. So all of the source of truth they're trying to point to that at this point. There may be a change of that in the future. HL7 is discussing having their own tool set to host some of these in the future. None of that is done yet. And the VSAC, we have agreed with NLM to actually have a yearly cycle release. Because guess what? We find new value sets or new value codes that need to be added to these value sets every year. And we also find that there's sometimes codes that are wrong. So there is a yearly update. So we're only going to do these one time a year, but they're usually happening in June. The last release was June 2018, and we just had one June 29th of this year. And if you want to search VSAC, you have to log in and basically go to the search button and click what you want to search. It brings up all of the actual value sets, but there's a little trick to it. And it's a little bug, and they're not going to fix it, so we're just going to work around it. But there are actually 136 value sets for the CDA templates and so forth. The way that the screen lists, you have to actually put how many you're looking for. If you put all 300, it won't let you download an XML file. It'll let you download an Excel spreadsheet, but that's it. If you need an XML file or you need it in a text file, you need to do the first 120 and then do 16 more. So that's a tip and trick. It's a workaround, but they said there's too much code to try to do it otherwise, and I don't know. I lost that argument, so we're just doing the workaround. So I'm sharing that with you. And again, we'll go over this more. There'll be probably a recording of this, so, and these slides are available, and I'm happy to answer questions via email or phone anytime to go through that part. So next thing to really point out, a lot of people keep asking me, well, what's the difference between your tools and the ONC meaningful use tools that are used in support of the meaningful use testing program. Those tools are listed under the site. So if you go to the site.nv site, there are some sandboxes. There's some CDA testing tools out there that are used by the authorized testing labs like Drummond and others to do the content testing. And what I've tried to do is summarize very fairly, and all these I have facts behind it, so this is Didi's assessment, so take that with a grain of salt, but I have spent a lot of time looking at both tools for a long time, and we did evaluate the site tools to use for ourselves. And to be very, very honest and for full disclosure, the reason we didn't use the site tools is because the modeling technology that's behind it is something called the Model Driven Health Tools, MDHT. And it's great, it's open source, but there's nobody else in the world using that modeling for any kind of content testing. Everybody else in the world, every other country in the world is using Art Decor, which is a different kind of modeling technology. So I went with the one everybody else was using, just because if you're going to support tooling, you want to keep the cost as low as possible. So if you can split your costs with multiple countries, it's a little bit cheaper. Now, I have been in discussions with ONC, Marianne Yeager and myself, and you know, with the roles that we're playing in different realms, we have been talking to them, and we're going to try to hopefully get this to a unified set somewhere in the future. There's no plans yet for that, but we are having discussions, so we would like to make it so you have one tool you point to. But some things to really point out that are different. Both are open source, so they're both level there. Unfortunately, the site tooling only tests certain document types. It does not test all 14 documents. It does not test all 70 sections. It does not test all 136 value sets. So it's not going to give you a complete picture of everything that's in your document that could be improved. So that's one little deficiency. Our tooling actually still tests the C32. ONC officially deprecated the support for the C32. They don't even accept that as meaningful use anymore. I know meaningful use is gone, but thinking forward of, you know, what are they're really thinking about, they had already deprecated it, and they said, why are you still supporting it? Oh, people are still exchanging it. And there's going to be the historical documents that you're still going to have to make sure you validate on. The value sets they have been testing on, the limited ones they have are from June 2018. They've not done an improvement update. They are going to, but they don't have a date for that yet. Ours, we updated, the value sets were posted June the 29th, and we actually updated our tools and had them available with the latest and greatest value sets by literally July 31st. So within 1 month, we had new tools with the new value sets adopted in it and available for use for testing. We are also trying to make sure we're very on top with the errata processing. So when we find a specification issue, something that's wrong in the spec, and we have found about a dozen, believe it or not, where in the tool somebody will say, well, this is saying it's an error, but in the spec it says it's here. In some cases, well, yeah, in one place in the spec it said one thing, and in another place in the spec it said something different. So there was an ambiguity there. So we had to work with HL7, bring things like that. There were other issues where they were bound to the wrong value set, OID, and things like that. So there's technical things you don't care about, but I'm working with, and I have folks that are even here that I've been working with the CDA management group, the structured documents work group. So HL7's been very supportive of helping and working with me when I bring these type of issues to them. But we're having to tell them, okay, here's something where the spec needs to be improved, and their way of doing that is through what they call errata. The errata was updated June 29th, and that was to coincide with the value sets because there were some symbiotic improvements to be done on both sides. So ours is current. I don't know at this point in time what errata they have incorporated. I tried looking through the release notes for their tools, and I couldn't find any place unless I just went one by one and tried to figure out, you know, if they had one errata listed here or there. So there was no unified listing of everything that it covered. Our tooling does store the testing report in what we call a permanent link. So you can go back and look at it at any time you want. Theirs does not store that report. So if you test a sample and you want to go back a month later and see what that report is, you have to rerun the sample. Ours stores that report for you. And as we improve tools, you can hit what we call, and I'll show you in a little bit in a screenshot, a validate again button. So like we just did an update actually over the Thanksgiving holiday on November 29th. All the people who've already tested, they can hit validate again and get the new report. So it'll show them what their errors are with the defects that we just fixed. We had 5 that we fixed. And then last but not least, to give them credit, they do have something incorporated that they're calling a scorecard. Their scorecard goes over and above meaningful use. So that scorecard kind of gives what I would call best practices. It was assembled through the Structured Documents work group at HL7, and it kind of raises the bar above meaningful use. And we did not incorporate the scorecard rubrics into our tooling. At the time, the content testing work group thought, let's just do these base specs and get everybody good there, and then we'll figure out where to raise the bar later. So they do a scorecard rubric test that we don't do, but in general, and everybody's reported this to me this way, our tools always report more errors than theirs does. So everybody's saying, well, why can't I just test against this one? It's got less errors. Well, you can, but you're not going to get a complete picture of what you're going to have to improve over time. So that's something to keep in mind. And again, not trying to say they're bad. It's wonderful they're providing that service, and we're going to try to see if we could maybe take and combine forces where we're using our modeling piece, which is, definitely robust enough to cover everything that you might need to test, but also be able to incorporate their scorecard in there. There is an API that we could call the scorecard. We could take that, run it through there, and bring back that scorecard information as well. So it's not something that there's no technical barrier for us to do that. It's just a matter of you telling us, do we want to include the scorecard rubrics too? And at the time, our testing work group only did the base meaningful use requirements. So those are the main differences between the tooling. So I wanted to share some of that with you because vendors are coming back and telling their participants, well, I'm meaningful use certified. I tested over here. I passed. I need to fix these errors. Well, you kind of do, based on the requirements that we call the validation plan that's tied very directly to the DRSA that you've signed. So those folks that have signed the DRSA agree to do the validation plan requirements, which have these ingrained that you shall pass all these things. And the tooling that we're using are enforcing the specs to the best of our abilities. I'm happy to report there were 15 organizations that have passed, but that only makes up 5%. Of all of our folks who have tested, only 5% have passed. And we expected that, so it's not anything bad. We did expect that improvement. We're wanting to get that even better, and we have been very encouraged that there's so many folks really doing their due diligence to make sure that we can work through the vendor requirements for remediation and working with their federated stakeholders. In some cases, the HIEs are saying, well, these are hospitals and we don't have control over them. They have control over their EHR. So they're having issues where they're trying to figure out, how do we work together? So I have also been partnering with the VA folks. They've been very good with supporting me. We've been trying to have more directed vendor calls. So the VA, through the Veterans Health Information Exchange, the VHE program, had been already doing some data quality improvement discussions with vendors. So we kind of joined forces and we started working together. So we're trying to have some regular cadence of calls to work with the vendors to help bring their attention to certain things. And some vendors are very much more engaged than others, so I'm not going to say that everybody's on board doing everything that they can do, but we're trying to do that in baby steps. So everyone who is validated, if you want to find out who those folks are, the URL link that's actually here, right beside the big logo that says Content Validated, will take you to the participants list, and all the participants that show this Content Validated logo are the ones that have passed. Also, you'll find there the hub, the hub responder or hub bidirectional, et cetera. So that's where we're trying to give you some transparency on who can do what. 95% have failed. And the main failures have been around things like the vocabularies. They're using the wrong ones. They have some custom configuration that their hospital are using their own value sets. That's fine, but it's not going to allow for that semantic interoperability that we really need. We need to make sure that we harness these IT systems to work smarter for us instead of us working harder, and the clinicians and the caregivers and the patients as well. So that, as well as things like the US RIM header, they're not including some mandatory fields. They may be using a wrong template ID. So it's all over the map, but the biggest ones are vocabulary and you know, some of the required fields. Now, there are many cases where nulls are allowed. So if you know, in the specification it says, yes, it's required, but if you don't have the data, here's how you say this is a null. I don't have this data. It's unknown or not available. There's certain codes that you put for that. So you can get away with not including that information if you don't have it, but if you have it, you're supposed to provide it. So just making sure people also appropriately null things. So some of the errors are, they're not putting a null, they're just leaving it blank, and that's not allowed either. So things like that. So it's kind of all over the map. I don't have a really good summary of all the unique errors across all the tests, but that's something that we're working with our tooling vendor to provide better reporting and analytics back to us to start doing some of that as well. We've had over 7,000 documents tested to date, and 70% of those are testing against the C-CDA Release 2.1 standard, which I encourage everyone, if you're not already on 2.1, move there as quick as you can. The reason I say that is because it fixed a lot of bugs. So C32 was very immature. It was very basic. So you definitely wanted to move off of that. 1.1 came out in 2014. 2014 was kind of a transition year, and everybody was trying to figure out what they wanted to do. And the Health Story project, hosted by HIMSS, put together some templated documents. So it was its first foray into, let's expand what kind of documents we provide, like discharge summaries and referrals and progress notes, things like that that you need for different types of encounters that you might, you know, have as a patient. So we found that people are starting to migrate there. So I'm very encouraged, because literally when we did the pilot in 2016, we had more like 70% C32s and 10% CDA Release 2.1s. So we have seen a market shift, so I encourage everyone, if they're not already supporting 2.1, try to do that as quickly as possible. The main reason for that is because it aligns with the US core data for interoperability. So you've heard that thing called TEFCA and the requirements that it has. Inside of that, it has US core data for interoperability requirements, which is based on 2015 Common Clinical Data Set. So that Common Clinical Data Set, they've added some additional data classes to. So if you're already moving toward that, at least you don't have that much more to do. So I would say bite the bullet sooner rather than later before you have to. And we are working, I said, with vendors to remediate these issues and helping educate, like what we're doing here with you today. I've had these conversations with vendors over and over, and participants, so that's why I kind of summarized them into slides for you guys to take advantage of. So again, the pain points, this is a slide that we used when we first launched the program. The main pain points are still the same, even after doing more robust testing after the pilot. What we're finding is that the same industry pain points exist with regards to optionality. So a lot of these different, what I call sections that are fitting into a document, in a document overall requirement list, there's going to be certain sections that are required and certain ones that are optional. So some people are just completely leaving the optional ones out. They're just saying they're optional, so I don't have to do them. But a clinician may need that data. So I would, really encourage all of those folks working with clinicians and physicians to start asking, okay, well, these are the types of things we could report on, but what do you need? Don't just do the bare minimum if you're a vendor. And if you're a participant, make your vendors do more. That's my advice there. But really trying to make sure that the optionality is not something that's going to be a barrier for you not including the data. Just because it's an optional field doesn't mean that you shouldn't include it as well for your needs. So really using your use case. Terminology, we already mentioned that that's another pain point that folks are having. The specification ambiguity. A lot of people don't understand how to read these specs. The HL7 CDA Release 2.1 spec is 900 pages long. Right? I don't like reading it either. But when I have to go spec spelunking and find out, okay, this person is saying this is an issue, and they're disagreeing with my tool, I have to go research it and say, yep, I agree, my tool has got a defect, or no, this is why you are wrong, this is something right. So there's some of that dialogue that happens back and forth as well. And then the complexity, which kind of goes with that spec ambiguity as well. So another item that I've been asked about a lot is, I need an example document. Give me a sample so I know how to code to it. I don't want to look at these specs. Give me some examples. So HL7 is the authoritative site that I point everyone to. And basically there is something called the HL7 CDA Example Search. And the URL is actually listed at the very bottom of the screen. So I did try to give you the breadcrumb. And this is where you can go and find examples. Now, will you find an entire document example? No. You're not going to find a C-CDA example in there necessarily. You're not going to find a discharge summary complete document in there. But you will find an allergy section, med section, social history section, all those different sections that you may be interested in including. They do have some gold standard approved section type of samples in there. So I encourage everyone to go there. There used to be a GitHub site that a lot of folks, vendors early on in the meaningful use days, used to put their samples to there as part of the meaningful use certification requirements. That's dated, so I would kind of stay away from that older GitHub site. I didn't even include it because I don't want you to go there. I would recommend going here. And if there are samples that you don't see in here that you would like, let me know. I can be your voice back to HL7 so that you don't have to sit in the meetings that I'm sitting in already. And I don't mean that badly because they are very important. Without the HL7 support, we wouldn't be where we are today. But I don't need you to be listening in on HL7 messaging type of discussions. I'm happy to bring those forward. So let me be your kind of conduit to bring that back to HL7 to say, hey, we need an example of this. Or I'm having customers ask for this. I can't guarantee that we'll get one right away because they do have a backlog. There is a list of samples other folks have already requested. But there are those type of items we can support you with as well. The data quality challenges are really impactful. You have to really think about, we are changing the paradigm of how people think. So you're harnessing the computer, but you're thinking different than what the computer's been configured. And I know this because I have an old dusty vendor hat on. I was a vendor for 16 years. And most likely the vendor hasn't really streamlined the workflow to account for how you do your day-to-day operations if you're a clinician or a physician. So really starting to think and be innovative with how you work with the data collection, how you view it. Like, you know, if it's a cardiologist, they may only care about looking at this on this page before they have to hit the page down or scroll. So trying to think about how to display information. Again, all that's not in your control, but being able to bring some of that feedback back to folks, you're going to have a better experience to have people finding the data as well. Because sometimes this data is exchanged, but it's not always looked at. If it's something that they have to go digging 16 steps down into. If they have to click 16 times, they're not going to go looking for it. The challenges really are to make sure that we're capturing this data robustly, to be able to exchange it. But it has to be in a structured way. You need to make sure it is coded as much as possible, whenever possible. And I know we can't do all of this overnight. I know we can't solve world hunger overnight, but again, little baby steps. And the innovation will continue because I expect that we'll continue raising the bar as we find new evidence-based best practices for clinical care to inform, now I need to gather this information. So it'll be something new, you know, maybe another baby step in the future. But really thinking about how to support what I can call normal transitions of care. What do you need to do to get this patient from this facility to another, whether it's a long-term care facility, a physical therapist, thinking about it from all aspects, public health, making sure to incorporate that. So thinking about working with others and seeing how you can incorporate the data as well. So summarizing, I kind of mentioned this earlier, but the C-CDA release 1.1 had 9 different document types, and they're listed over here to the far left. So those 9 document types were originally released. Well, with the 2.1 release of HL7, there are now 14 total document types, and they added these to the right-hand side. Clinical note is one of those that are now part of the US CDI here. And then the patient-generated summary. I heard several sessions this morning, and I'm encouraged because I'm a caregiver and I am a patient. Luckily, I don't have that many medical issues, but I do have elderly parents that I'm handling their caregiver instructions and helping them through their patient process. So just making sure that you become aware that these do exist, and don't think of just one document to try to be a one-size-fits-all, because that's not how clinicians work in the paper world, but now they're trying to be expected to do this in the computer world. So remember, you're force-feeding them saying, okay, this is the only thing you're going to get. Well, maybe they want more, so try to work with those that are using that data to help understand and help support them. I think you'll find that there's lots of innovation that's being left on the table. The patient story needs to be told, so you need to think about it from that encounter basis. Out of those 7,000 documents that are being exchanged, over 75% of them are C-CDA documents. So we are still that one-size-fits-all. 75%, probably 75 to 80% are C-CDs only. There is one other document type that I see fairly regularly being used, and that's a progress note. But to be honest, in all the different testing that we've done with those 7,000 documents, the majority are two document types, progress notes and C-CDs. So I really encourage you to think about what are their document types. In a discharge summary from a hospital, well, it's going to give you a lot more information from the hospital perspective. What was the admission diagnosis? What was the discharge diagnosis? Things like that that wouldn't be part of a C-CD typically. Now, one thing to point out, all of these different document types are what are called open templates, meaning these are Lego blocks. You can take and intermingle any one of these sections. There's 70 sections. Maybe a C-CD has 17 total and only 5 required. That doesn't mean you can not pick some of those other 70 that are important to you. So you can customize it. It's kind of like a little Lego city. You can decide how to build this on your own as you need to. And this is an example. I borrowed this slide. They no longer have it posted on the HIMSS website. This actually was a webinar slide, and I think Dr. Lane has used this. I helped bring him up to speed on some of this way early on, so I've reused the slide again, and if I could give him credit, I would, but I don't see it posted anywhere anymore. But for full disclosure, this came from Lisa Nelson's presentation under the Health Story Project, so giving her full credit here. But this is an example where she built out just 2 document types, just so you'll understand kind of what I'm talking about. And what we call the transfer summary that's over on the left side, these are the sections, and you may not be able to read these back there, but these on the far left are the required. So those are the required, what we call sections, with all their entries underneath them. These are all the potential optional ones that were part of the transfer summary. But a C-CD document has these required sections and these optional ones. But there is some overlap. You're going to find both have meds, they both have allergies. There's some overlap there. So start thinking about these sections. Don't just think about the document type only. Think about what is it that your clinician for cardiology, oncology, orthopedic, whatever specialty they are, what data do they need to take care of that patient when you're referring them or discharging them on from the hospital? So thinking about these as interchangeable Lego blocks that you could work with your vendor to configure. Now, some vendors will not have the ability to do this, so I know that I'm maybe wishfully thinking here. But if you start asking, they're more encouraged to try to do that. So again, I try to just make sure to encourage the dialogue, make sure that there are those discussions, and then let me know if there's something I can do to help. These are things that I can also help make cases for if needed. These are the 70 sections in total, so I'm not going to spend a lot of time, but this gives you all the little widgets so that you can use this later to look at, so you don't have to read the 900-page document and filter through and find all those different section listings. So why it's important, I think I've already summarized that, but really making sure to use the right document type for the right situation. I'm trying to summarize this one slide here. Making sure to think about what the right context is. Do you need to include some of the social history that maybe would be helpful in some different care settings and things like that? So thinking about it from an innovation perspective. I had to throw in the Lego blocks since I use that a lot. I still play with Lego. I admit it. But it's one of those things that I want you to build your own little Lego ecosystem, and Jay's over here laughing. I had to include it. I thought, okay, I'm going to keep them awake after lunch. But I want you to build your Lego cities and hopefully make it so that the clinicians and physicians really can feel happy with what they're starting to get in the way of data. So again, making sure that the content is prioritized based on what would be most useful for each of those clinicians or physicians downstream. Making sure to work through data mapping issues. So if you are using your own custom value sets that a hospital has created on their own, maybe they're a large integrated delivery network and they have their own code system because they're doing a lot of research or whatever. Make sure that there's some understanding of, okay, yes, these are codes, but these are other codes that are supposed to be used, so making sure there's some mapping or things like that. Mapping always gets difficult because interoperability, whenever you require mapping, it always ends up meaning that you have to pay for some sort of interface. So try to avoid that as much as possible. And then really making sure to start thinking about how to identify the sources for data. You want to make sure that provenance is thought about because the US core data for interoperability does require some of that now. So real quickly to start summarizing a bit and give you these tidbits, and these are all screenshots, there has also been some defects reported with the tooling. We have had a few dozen, so I'm not going to say it's a huge number, but we have had now the validators rebuilt. Since 2018, we've had them rebuilt 4 times. And we've remediated issues all 4 times. This most current one, we only had 5 issues to remediate. The last remediation we did was in July 31st of this year. We did another one November 29th, so about 4 months later. I'm trying to average 3 to 4 per year, about once a quarter or less if possible, but trying to not let things pile up too much. So what we want you to do is anytime you find that you think you have a tooling defect where you disagree, the tool's wrong, that's okay. Send an email to testing@sequoiaproject.org. Include screenshots. Those are the most helpful of all. In the tooling, include the permanent link. And what we mean by a permanent link in the tooling is this URL that the tooling gives you. So include that permanent link. Send the permanent link. You don't have to send me the XML. I can get the XML from the tool. And the screenshot of the actual error that you're wanting me to look at that you think is wrong. And the tool will give you the information. And several of the errors that I've been remediating are where, oh, well, the spec says it's a should. That should give you a warning. It's giving me an error. So, okay, I'll work and I'll reduce that to a warning. You don't have to fix warnings. You only have to fix errors. So there's been some of those that we've had to remediate where the model was a little bit wrong. And then last but not least, give me in the spec where you think it's wrong. Give me where it says in the spec for that conformance why you think it's wrong. I can go look in the spec, but if you've done your homework, then I know that you've got a good argument, and I'm going to take the time. If I have to spec Splunk, I'll still do it. It's very quick and easy for me to make a real quick determination if I see this, because I can go prove it real quickly, and make sure that there's something that I can make my tool vendor fix right away. These are the 5 issues that were remediated as of this last validation process. We were, for full disclosure, including this information, all of these were listed on the front page of the test tool. So every time we find a defect, the moment we identify it, we add it to the front page of the tool. So always look as you're doing testing, because this is a continuous process. It's not going to be a test 1 and be done. You're going to continue being tested, hopefully. And make sure you look at the front page to see if there's an actual conformance number that you're seeing an error. You can know to ignore that. Right now there are 0, so there's nothing that you should be ignoring. They should all be right, but if you find one that's wrong, let me know and we'll work through it. Again, these are not always perfect out of the gate, but we're checking hundreds of thousands of different things, so there's always prone to have some sort of error. The tool gives you kind of a pass-fail report. You can drill down into the pass-fail, and it lets you actually, I mentioned earlier, revalidate the actual sample. There's a validate again button up here. So if you've tested something, and I've just done this tooling update, which, by the way, I've not officially announced yet. I have to get an email out, but I've been at another conference for 3 days already, and I've got this one, so you'll get an email next week. But as of November 29th, and I did try to take Thanksgiving off, November 29th, the tools are updated, so I'm going to be sending out a message to everyone except the Epic customers. Epic's going to work with their customers directly, but we are going to send out an announcement saying we've updated the tooling, so if you're not here or other participants are not here, we'll let them know that they can hit that validate again button, and then they'll know exactly what errors. If there were some that were remediated, they'll disappear off the report. If it still says the same number, then they'll verify that they have no new things to remediate. The tooling actually gives you not only the model-based validation, there is a tab up here that's called model-based validation and one that's called Scorecard. There's two ways to slice and dice the report and get you back the information. The model-based validation one gives you something that looks similar to the site tooling. So it gives you kind of a summary of errors, gives you the numbers. We've also tried to include hyperlinks. So there's little eye icons that you'll push within the result, which will take you right to the XML. You can also slice and dice it. In the right side of the tool, there's a little check mark right here that's called templates. If you want to see exactly how many errors are in the allergy section alone, you can click on allergy section and it'll give you just those errors. Nobody knows that. I've said it before. It's in the documentation, but not everybody's seen that. So I'm trying to point out that you can actually, if you just want to focus on certain things, you can focus it that way as well. Content-sensitive drill down, this is what I mentioned again, the little eye icon. This is what it looks like, because I figured you couldn't see it in the back of the room, but this is the eye icon. You click on that and you get this. It takes you right into the XML. It gives you the error, and you'll see within the XML exactly where the problem is. So making sure to use this tool. And again, it's stored permanently, so you can look at it, and then you can share that link with your vendor directly. You can share it with the little buttons, and they can actually get into it without even having to log into the tools. So we've tried to make that easy enough to do. The Scorecard tab is the other way that we slice and dice the data, and that Scorecard tab actually makes you do something called Get Scorecard. Now this takes a moment. You may take 45 seconds for this to come back. So I know it's not as fast as it could be. We've tried to optimize it as much as possible. What it's doing is it's going through the whole XML report blob, and it's coming out and saying, what's your discrete errors? So what it does is when you click that button, it actually brings you back a report. It gives you this little icon, so it's going to spin for a few moments. I know it may be a minute or two even, with really large documents, and there are a lot of those. It may spin a little bit, but then it's going to give you kind of a summary of how many are vocabulary errors, how many are constraint errors. It's going to tell you by kind of category what it is, and then it's going to list them uniquely, and it'll say, okay, this error's happened 21 times or 18 times. So you can then say, okay, out of the 40 errors, 21 of them is this one item. Let me take that one. You always get a sense of satisfaction if you take and squash a whole lot of bugs all at once with doing only one thing. So trying to look at how to slice and dice that. The tool does this for you. So use it, leverage it. Again, trying to speak. A lot of times I get XML blobs that look like this. It's just a big wraparound code. The tool even has the ability to take and do what is called indent file. You click this little thing and it makes it nice and readable. So you can even do that. The tool does that for you too. And then last but not least, HL7 publishes 2 different style sheets from how to actually display documents. These are both approved style sheets that are published with the HL7 spec. And this one on the far left is the older style sheet that came with the older versions of CDA. As of the publication of the C-CDA release 2.1 that was published in June, they added this new style sheet. So there's 2 ways. If you are not clinical or not technical and you don't want to look at the XML, you can look at it this way. This is what the clinician's going to look at, more or less, depending on how the vendors put their style sheet on it. But this gives you a human-readable form, a little bit easier to navigate. So with that, that's the tips and tricks. I'll take any questions that you might have. Yes, Bill.
Hi, Bill Howard from Remediation Inquiry. First of all, thank you, Didi. This is just yeoman's work. It's amazing, and so I know how hard it is. This is actually not really a question to you, but maybe to the group. So if 95% are not passing, and yet I hear about some pockets of awesome interoperability happening, what's going on here? Why is this not adding up? So I don't know, maybe it's a question to some of the Epic to Epics, or maybe Paul, you can ask, see, but I'm just curious why that doesn't match, if you have any thoughts on that.
Well, I guess, remember, I'm testing every single thing, and every vendor may not be digesting semantically every single thing. They may be only digesting those 5, 7 sections. So I'm finding errors in things that maybe nobody's even injecting or accepting internally, or even displaying in the first page. So it may be that there's interoperability. I'm not going to say there isn't, but when you need the machine to be able to semantically take it in and not just have a view, this is what you kind of need to do. So I think that's why I think there is interoperability, but how many people are actually absorbing that information and importing it into their EHR? But again, others can maybe give better.
The follow-up question is, can we take some of those that seem to be interoperating and make sure that they pass or fail? So maybe, I'm just wondering if maybe we need 2 tiers or something.
Absolutely, and we are, I didn't really address it yet because we don't have timelines around it, but one of the things I'm asked about a lot is how do we do testing with real production, PHI, because what they've been testing, a lot of them have had to de-identify the information, so we're gonna try to do that so that there'll be more continual testing. And there have been some requests to have this as a stat back on the dashboard and things like that, so we'll definitely work. Next question.
My first question
Oh.
was about PHI, but that was answered because that is where you really see
The real
what's
difference.
happening and not artifactual from de-identifying. The most common problem I see when I look at C-CDs is people putting empty units on lab tests. It drives me crazy. It fails the basic schema validation if you do that.
Yep.
So if you're talking to your vendor, even more so than codifying data. But I will tell you that there are a lot of payers that are using the C-CDA data for quality measures. And their biggest challenges, other than if the C-CDAs are being done incorrectly, I've heard in some of those instances they're reporting future encounters as actual encounters. So things like mammograms are being reported as done and they haven't been.
Yep.
And you can't necessarily detect that with your
In
type
the testing tool.
validation.
No, you can't. You're
Because
right.
if they're putting it in encounter section, you wouldn't know.
Yeah, exactly.
But encourage your vendors to use those code sets. And to, now NCQA this year came out with SNOMED added to their code set. So those will now help. And so it's SNOMED code. And the second thing I see the most common around the quality issues is dates. I get
Yes.
null flavored dates all of the time. And it does it, I don't know if vendors are under the misimpression that they can't send like less than a full date, in the C-CD, because if a hysterectomy was done in 2009, that still is helpful.
Yeah, 2009
It
is better
doesn't have to
than
be
nothing.
January 5th, 2009.
You're right.
So, and I think sometimes the systems are just recording it as 10 years ago or something.
You're right.
And that's not helpful.
That's, by the way, that's Linda. She's on the CDA management group, so she's been very supportive on the HL7 side, so I'll call her out for that. Next question.
Yeah, have you also thought about the XDS metadata as it pertains and matches to the C-CD and use that as a validation methodology? Because the specifications are pretty trite in that area.
We've separated the transport from the content right now. There is plans in the future, probably. Again, the coordinating committee has to tell us and advise us, as well as the membership. But we will like to join transport and content testing together so you can see if the metadata matches the payload piece. We chose consciously not to do that as the content testing work group because they wanted to crawl before they ran, and they knew that we had a lot to do on the content only. But the tools can do that today. It's just you tell us when we need to turn it up.
Another forethought is, with 2.1, you got data providence is the kind of the key call out. That then lies into helping to kind of algorithmatize, or whatever you want to call it, the deduping.
Yep.
I would seriously consider a deduping lens later on as you start to get into that, especially when you use identities and and the context of identities and so forth. Like she
Absolutely.
talked about dates as being important, so.
Absolutely. And we may spin up a content work group again. I know Care Quality just did a content work group, and they're raising the bar just a little bit. So again, if you have appetite to do new things, we do not have, for full disclosure, we do not have provenance on here yet because Meaningful Use did not report that. But if we wanted to go ahead and turn that up, I can add those templates and start testing for that as well. We just know no one's doing it right now. So they're going to fail that too. So any other questions? All right, I think I'm out of time, so thank you.
Thank you, that was wonderful.
No problem.